In this video, we will step by step break down the major features of carbon monoxide poisoning. As we see, carbon monoxide poisoning and cyanide poisoning have similar features, and sometimes, for a student, it can be problematic to tell which condition is it. So let's explain what is the major difference between carbon monoxide and cyanide poisoning. The similar feature is that both these conditions target iron. We have iron in the mitochondria because we use plus-recharge iron as a cofactor for cytochrome C, also known as complex 4 in electron transport chain. And also, we have a lot of iron in the red blood cells. Red blood cells use hemoglobin, which contains plus-2 charge iron, to bind and carry oxygen to the tissues. The major fact about carbon monoxide is that carbon monoxide loves plus-2 charge iron more than plus-3 charge iron, which means that once carbon monoxide comes to organism, most of the carbon monoxide molecules will bind to plus-2 charge iron inside the red blood cells, thereby blocking oxygen delivery to the tissues. The major reason why practically all carbon monoxide binds to hemoglobin is that the affinity of carbon monoxide to hemoglobin is 200 times higher compared to oxygen. So red blood cells are the primary target here. And the small amount of carbon monoxide which is left will go to the mitochondria, where carbon monoxide will bind to plus-3 charge iron in complex 4. In contrast to this, cyanide loves only plus-3 charge iron. So cyanide is not interested in red blood cells. Cyanide goes straight to the mitochondria, blocking cellular respiration, which is more dangerous. To explain the pathogenesis of carbon monoxide poisoning, first of all, we have to recall normal physiology. We transport oxygen by the hemoglobin. Hemoglobin has 4 iron molecules. These iron molecules have +2 charge, and only iron with +2 charge can bind oxygen molecules. Initially, we have deoxygenated hemoglobin. In simple words, it's hemoglobin without oxygen molecules. To pick up oxygen, hemoglobin goes into the lungs. In the lungs, with inhalation, a lot of oxygen molecules come to alveoli. The concentration of oxygen molecules is described by the partial pressure of oxygen. In the lungs, the partial pressure of oxygen is 100, which is huge. This high partial pressure of oxygen makes able for hemoglobin to bind 4 oxygen molecules. With these 4 oxygen molecules, hemoglobin enters into the blood. And hemoglobin, where every iron has oxygen, we call 100% saturated hemoglobin. The oxygen which is located in our blood in bound to hemoglobin form, we call bound oxygen, and it's a major fraction of oxygen in our blood. In contrast to this, we also have free or so-called dissolved oxygen, which is a minor fraction. Both bound and dissolved oxygen are going into the tissues where they participate in cellular respiration. The classic scenarios of carbon monoxide poisoning are car exhaust in closed garages, gas heaters, generators, and home fires. Once we inhale carbon monoxide crosses the alveolar membrane just like oxygen. In the bloodstream, carbon monoxide binds to hemoglobin almost instantly. The reason is that carbon monoxide has 200 times higher affinity for hemoglobin compared to oxygen, so there is absolutely no chance for oxygen in this competition. Hemoglobin, where iron molecules carry carbon monoxide, we call carboxyhemoglobin. So the first diagnostic marker is elevation of carboxyhemoglobin on CO-oximetry. The major problem is that carbon monoxide holds to hemoglobin so tightly that it takes 8 to 10 hours to remove carbon monoxide from the circulation. So the period of half-life of carboxyhemoglobin in the environment with normal partial pressure of oxygen, which is approximately 100, is 4 to 5 hours, It's crucial because it's the period of time when tissues will not receive oxygen, and with decrease in oxygen uptake, cell respiration will decrease, which will cause tissue hypoxia. In addition to this, once carbon monoxide binds to hemoglobin, it causes left shift in oxygen dissociation curve. And because left shift leads to decrease in oxygen delivery to the tissues, it makes tissue hypoxia even more severe. So let's explain what is the left shift and how it affects oxygen delivery. And to explain this, we have to recall hemoglobin structure and how oxygen dissociation occurs under normal circumstances. So here we have simplified hemoglobin structure. There are 2 alpha and 2 beta chains. Each chain has iron with +2 charge. Each iron with +2 charge can bind 1 oxygen molecule. So in total, hemoglobin can bind up to 4 oxygen molecules. If hemoglobin has just 1 oxygen molecule, we say that hemoglobin saturation is 25%. If hemoglobin carries 2 oxygen molecules, its oxygen saturation becomes 50%. 3 oxygen molecules give saturation 75%. And if hemoglobin has 4 oxygen molecules, it's 100% saturated hemoglobin. The most important feature about hemoglobin is that hemoglobin is allosteric protein. It has positive cooperativity in relation to oxygen. First of all, what is an allosteric protein? An allosteric protein is one whose function or shape changes when a molecule, like oxygen, binds to it. This change affects how it interacts with additional molecules. Hemoglobin exhibits allosteric behavior when hemoglobin binds oxygen. This means that the binding of one oxygen molecule to one subunit enhances the binding of oxygen to other subunits. So, because hemoglobin is allosteric protein, if one oxygen molecule binds to hemoglobin, it causes a conformational change in the hemoglobin molecule. This change makes it easier for the remaining subunits to bind additional oxygen molecules. In smart words, hemoglobin affinity to other oxygen molecules increases, and because the binding of one oxygen molecule enhances further oxygen binding, we call this phenomenon a positive cooperativity. We have to know that the only thing that can force hemoglobin to give away oxygen is decrease in partial pressure of oxygen. Partial pressure of oxygen is basically the concentration of oxygen molecules. The lower the partial pressure of oxygen, the more rapid is oxygen dissociation from hemoglobin. For example, with partial pressure of oxygen 100, the dissociation is 0. Hemoglobin gives away the first oxygen molecule only when partial pressure of oxygen becomes lower than 40. The dissociation of 2 oxygen molecules occurs only with partial pressure of oxygen lower than 26. And 4 oxygen molecules dissociate only with partial pressure of oxygen near 0. And now, knowing this, we can discuss oxyhemoglobin dissociation curve. So here is partial pressure of oxygen, and here is oxygen saturation. For comparison, let's suppose that without positive cooperativity, partial pressure of oxygen and oxygen saturation have linear relation. And this purple curve is how oxygen dissociation occurs in real life due to the positive cooperativity. In oxygen saturation, we are interested only in points where hemoglobin gives away oxygen. So it's a point where hemoglobin loses 2 oxygen molecules and becomes 50% saturated, a point when hemoglobin loses first oxygen molecule and becomes 75% saturated, and loss of 3 oxygen molecules make hemoglobin 25% saturated. We have to know that our tissues have partial pressure of oxygen between 20 and 40. So this red area is where hemoglobin should drop oxygen molecules. And it's vitally important for hemoglobin to drop oxygen precisely into this area and not earlier, because otherwise tissues will not receive oxygen. Once carbon monoxide comes into the blood, it immediately substitutes oxygen in hemoglobin structure, simply because carbon monoxide has greater affinity for hemoglobin than oxygen. The second problem is that with binding, carbon monoxide increases hemoglobin affinity for oxygen. So now, hemoglobin holds oxygen molecules more tightly. Because carbon monoxide substitutes oxygen, hemoglobin-oxygen saturation decreases. So before, oxygen saturation was 100%, for example, and now oxygen saturation can be just 50%. And as we see, decrease in oxygen saturation is one of the diagnostic features of carbon monoxide poisoning. So to summarize this step, carbon monoxide with binding increases hemoglobin affinity for oxygen. This forces hemoglobin to hold oxygen more tightly, and as a result, hemoglobin will release oxygen in the environment with a lower oxygen pressure. For example, previously, hemoglobin released the first oxygen molecule at a partial pressure of oxygen 40, and now it will be 20, and the second oxygen molecule was released at 26, and now it's 10. So it makes harder for tissues to get oxygen, and this makes hypoxia even more severe. So let's illustrate this. Here we see a normal oxygen dissociation curve. Here we can see points where hemoglobin releases oxygen under the normal circumstances. With anemia, hemoglobin saturation becomes 50. So because there are 2 times less oxygen molecules which are bound to hemoglobin, the graph becomes 2 times shorter. And also, we see that anemia causes a right shift as an adaptation mechanism to make tissue hypoxia less severe. But with carbon monoxide poisoning, even with the same 50% saturation, we see that graph is shifted to the left. And this makes oxygen delivery more difficult. Let's explain why. In anemia, hemoglobin picks up oxygen in the lungs, which have partial pressure of oxygen 100, and hemoglobin delivers oxygen to the point where oxygen pressure becomes 20. So distance of oxygen transportation is 80. Let's suppose that hemoglobin with oxygen moves at a speed 10 mm of pressure per minute. So it takes 8 minutes for hemoglobin to transport 1 oxygen molecule to the tissues with 50% hemoglobin saturation, but without carbon monoxide. In case of carbon monoxide poisoning, hemoglobin picks up oxygen in the lungs, so it's the same, but the release of oxygen occurs at a lower partial pressure of oxygen due to the high affinity of hemoglobin for oxygen. So because of this, distance becomes larger. 100 minus 10 is 90. The speed of hemoglobin is the same, and because distance becomes larger and the speed remains the same, the time of oxygen transportation increases. So now it takes 9 minutes for hemoglobin to deliver first oxygen molecule to the tissues. So as we see, left shift increases the risk of tissue hypoxia. So not only the delivery of oxygen by the blood decreases, but also the release of oxygen from the hemoglobin decreases, which is additional factor that predisposes to hypoxia. Also, small amount of carbon monoxide can leak into the cell, where carbon monoxide, by binding to +3 iron in the mitochondria, inhibits the function of cytochrome C. This results in mild inhibition of cellular respiration. So, as cyanide, carbon monoxide can also inhibit aerobic metabolism. But in case of carbon monoxide, it's a minor effect, because the major target are red blood cells. Nevertheless, let's explain the pathogenesis behind inhibition of cell respiration. To explain this, we have to recall oxidative phosphorylation. So, its mitochondrial outer membrane, its inner membrane, and its intramembrane space. On inner mitochondrial membrane located electron transport chain that is composed of 4 protein complexes and coenzyme Q. And also there is fifth complex called ATP synthase that has its own unique function. The general concept is that protein complexes in electron transport chain by transportation of electrons suck energy out of electron. 50% of energy complexes used to drive hydrogen protons from mitochondrial matrix to intramembrane space. But another 50% of energy goes to generate heat to maintain our body temperature. This hydrogen movement occurs at the level of complexes 1, 3, and 4. The major idea of this hydrogen transportation is to lower protein concentration in mitochondrial matrix and to increase hydrogen proton concentration in intramembrane space. This process results in creation of hydrogen proton concentration gradient through the inner mitochondrial membrane, with high hydrogen concentration in intramembrane space and lower concentration in mitochondrial matrix. And ATP synthase uses concentration gradient, and by transportation of hydrogen protons by concentration gradient into the mitochondrial matrix, it generates energy. This energy generated by ATP synthase we use for phosphorylation of ADP that results in production of ATP molecules. So, protein complexes suck energy out of electrons, one after another, until electrons will be completely energy depleted. And after complex 4 sucks the last portion of energy out of electron, now electron has no energy inside. Such electron is a wasted material that does not have any value for electron transport chain. So complex 4 throws out this low energy electron from electron transport chain to oxygen inside the mitochondrial matrix, and electrons bind to oxygen and reduce oxygen with formation of water molecules. Electrons are delivered to electron transport chain by the mobile electron transporters as NADH and FADH, and each of these transporters has its own site of delivery. NADH transports electrons to complex 1, FADH transports electrons to complex 2. Both cyanide and carbon monoxide can bind to +3 charge iron, and by this they inhibit complex 4. The difference is that cyanide inhibits irreversibly, and carbon monoxide inhibits competitively. So cyanide is a more potent inhibitor. And also recall that in case of cyanide, all cyanide molecules go into mitochondria, but in case of carbon monoxide, most molecules bind to hemoglobin. So inhibition of complex 4 in case of cyanide poisoning is more severe compared to carbon monoxide poisoning. With inhibition of complex 4, the transportation of hydrogen ions through the inner mitochondrial membrane decreases. This results in decrease in hydrogen concentration gradient, and the lower is hydrogen concentration gradient, the lower is the production of energy by ATP synthase per 1 electron. And decrease in energy production causes decrease in ATP production, which results in energy deficiency. So, decrease in transportation of oxygen by the hemoglobin, left shift, and to a lesser extent decrease in oxidative phosphorylation, all together lead to a severe tissue hypoxia. The most sensitive to hypoxia is neural tissue, particularly brain. So in hypoxia, patient can have headache, vomiting, confusion, visual disturbances, and coma. Also, they may have cherry red skin with bullous lesions. Let's explain the pathogenesis of this symptom. The reason why carbon monoxide causes cherry red skin is that carboxyhemoglobin absorbs light in the same fashion as oxyhemoglobin, which means that it looks like a fully oxygenated blood. So carbon monoxide poisoning creates an illusion of well-oxygenated skin. Bullous lesions develop due to a direct ischemic injury, which is caused by a combination of severe tissue hypoxia, prolonged immobilization, pressure necrosis, and epidermal-dermal separation. The signature feature of carbon monoxide poisoning is bilateral globus pallidus on MRI. It's an important diagnostic feature because in cyanide poisoning, typically globus pallidus is absent. So why is that? Globus pallidi has a lot of mitochondria due to a very high metabolism. This makes this structure very vulnerable to hypoxic injury. Globus pallidi is not a very specific sign, because in addition to carbon monoxide poisoning, it can develop in methylmalonic acidemia. It can be caused by disulfiram toxicity or by cocaine use disorder. Here we can see the symmetric lesions on MRI. Bilateral globus pallidus is basically the necrosis of neural tissue. Necrosis needs time to develop. Carbon monoxide poisoning usually is prolonged or subacute, and this gives time for necrosis to develop. In contrast to this, cyanide poisoning is very rapid and systemic. And because cyanide poisoning causes death within minutes, brain does not get time to develop localized necrosis. So it's the reason why the presence of bilateral globus pallidus tells us that most likely it's carbon monoxide poisoning and not cyanide poisoning. But what do we understand by hypoxia? Hypoxia develops when tissue oxygen demands are higher than oxygen delivery to the tissues. The normal tissue oxygen demands is approximately 5. The normal fraction of dissolved oxygen is 0.31. This means that practically all oxygen tissues receive from hemoglobin. So let's suppose that patient is breathing the room air, which has a normal partial pressure of oxygen 100. In these circumstances, with the presence of carbon monoxide, bound oxygen is not available for 8 to 10 hours, and the fraction of dissolved oxygen is miserable and cannot cover tissue oxygen demands. And without any treatment, 8 hours of hypoxia will eventually cause death. So how we can prevent this? There are two options. It's 100% oxygen and hyperbaric oxygen. Let's explain how this works. So here we can see the cycle of bound oxygen. So basically it's a pathway how hemoglobin delivers oxygen to the tissues. Once carbon monoxide comes to the bloodstream, carbon monoxide substitutes oxygen simply because carbon monoxide has a high affinity for hemoglobin. This results in formation of carboxyhemoglobin, which is a totally useless substance because it cannot carry oxygen. What we have to know is that the only thing that can force carbon monoxide to leave hemoglobin is partial pressure of oxygen. Basically, the higher the oxygen concentration in inhaled air, the faster carbon monoxide will leave hemoglobin. And with room air, which has oxygen pressure 100, the half-life of carbon monoxide is 4 to 5 hours. So only after 8 to 10 hours, organism will have oxyhemoglobin, which will begin to deliver oxygen to the tissues. So knowing that the only factor which can convert carboxyhemoglobin back to normal hemoglobin is partial pressure of oxygen, we developed two therapeutic methods. First of all, it's a breathing through the mask 100% oxygen. This increases partial pressure of oxygen to 700, and in such environment, the half-life of carboxyhemoglobin becomes 60 to 90 minutes. The more effective, but in the same time the more dangerous approach, is hyperbaric oxygen. we put a person in camera with oxygen pressure 2000, and in this scenario, the half-life of carboxyhemoglobin becomes 20 to 40 minutes. So, by increasing the partial pressure of oxygen, we can stimulate the dissociation of carbon monoxide, which will result in a faster normalization of oxygen transportation by the hemoglobin. But not only the bound oxygen fraction increase, dissolved oxygen in this case also plays an important role. With 100% oxygen, we increase oxygen concentration in the inspired air. First of all, it causes decrease in half-life of carboxyhemoglobin. So now the duration of hypoxia will decrease. But also, it causes increase in fraction of dissolved oxygen. And if in case of 100% oxygen, dissolved fraction cannot cover tissue oxygen demands, but still 1.8 is a significant number and a great help to hypoxic tissues. In case of hyperbaric oxygen, the concentration of oxygen in the inspired air becomes so high that it not only makes the duration of hypoxia shorter, but also, in this case, even the fraction of dissolved oxygen can fully cover tissue oxygen demands. But this method has a higher risk of oxygen toxicity, so hyperbaric oxygen we use only in severe cases.